Good afternoon, everyone. We will be waiting for about 1 or 2 minutes and we'll start our session. Okay, good afternoon again, everyone. It is my great pleasure to welcome you all to the second day of the second annual research conference organized by MRL. My name is Rehan Nursama and I'm a medical student at Addis Ababa University and also the president of Ethiopian Medical Students Association at Addis Ababa. As we continue from yesterday's insightful discussions, I want to express my gratitude to all the presenters, reviewers, and participants who have contributed to making this conference a success. Today, we have an exciting lineup of presentations that will be showcasing innovative research and critical findings in various fields of health and medicine. Each presentation will be followed by a Q&A session where our esteemed reviewers will be providing their valuable insights and feedbacks. I encourage everyone to engage actively in the discussion and to share your thoughts and questions in the chat box. And let's embrace the opportunity to learn from one another and contribute to the advancement of healthcare in our communities. So without further ado, let's begin our today's session. I'm pleased to introduce our first presenter. Our first presenter today is Dr. Ilan Tasfaye Bayena. She is an internist with an MD and MPH, Department of Internal Medicine, College of Health Science, Addis Ababa University. Dr. Ilan will be presenting the results of a retrospective cross-sectional study titled Isolated Pathogens, Antimicrobial Resistance Pattern, and Clinical Outcome of Patients Admitted to Intensive Care Unit of the Kurambasa Specialized Hospital from May 2023 to October 2023. Please join me in welcoming Dr. Ilan Tasfaye Bayena to the stage. Dr. Ilan, you have the floor.
Thank you, Rihanna, for the warm introduction, and good afternoon, everyone. I will be sharing my slides and I'll be going ahead with the presentation.
Dr. Eden, can you hear us?
Yes, I can hear you, but I'm having difficulty sharing my screen.
All right.
Is it okay? Maybe if you can share it from your, if you have the
Okay.
slides.
Okay, let's check with our admin. Try to start as soon as you can so that you can use your time properly. Dr. Eden, are you with us?
Yes, I'm here, but I'm having a difficulty sharing my slides. So maybe if it's okay, you can share it if you have the slides, since we've shared our slides with the team.
Okay, it has already been described in the chat box that you can use the settings to share your slides. Have you tried that?
I have tried it, but it says it's unsupported.
All right. Dr. Eden, can you attach your slides in the chat box?
I'm going to do that, yes.
All right. Okay, you may start, Dr. Eden.
Thank you. Sorry for the inconvenience. Thank you again, Liana, for the warm introduction, and good afternoon, everyone. I'll be directly heading to presenting my research titled Isolated Pathogens, Antimicrobial Resistance Pattern and Clinical Outcome of Patients Admitted to the ICU of the Kurambessa Hospital from May to October 2023. Next slide. So as an introduction, antimicrobial resistance in simple terms is when organisms stop responding to drugs that they used to respond to before, and it has been declared by WHO as one of the top 10 public health threats. And in fact, in 2017, WHO has listed carbapenem-resistant organisms like carbapenem-resistant Acinetobacter baumannii, carbapenem-resistant Enterobacterales ciaris, and carbapenem-resistant Pseudomonas aeruginosa as priority 1 critical pathogens, which demanded urgent discovery of antibiotics. And since then, polymyxins, ampicillin sulbactams, and other sulbactam-based antibiotics have been in use. And ESCAPE was an acronym that was used for highly virulent and antibiotic-resistant bacteria, leading to life-threatening nosocomial infections. But overall, this matter tends to be worse in the ICU, where critical patients are prescribed antibiotics left and right. It's also a place where most patients are undergoing invasive procedures and have indwelling devices, so it makes ICU a hotspot for resistant pathogens. Next slide. So the rationale of this study was that various initiatives like Global Action Plan, One Health Initiative, and even a declaration was signed by the UN General Assembly to tackle issues with antimicrobial resistance, but no significant improvement was witnessed, especially in the low middle income countries, due to reasons like poor surveillance, antibiotic overuse, insufficient diagnostic capacity, poor infection prevention and control, and use of antibiotics for agricultural purposes. Even though the vast majority of the literature showed a direct relationship between antimicrobial resistance and mortality, there were some inconsistencies showing that antimicrobial resistance is not a true cause of mortality, or causality seemed unclear. Next slide. So having said that, the objectives of the study were to identify the commonly isolated pathogens, their resistance pattern, the clinical outcome of patients, and associated factors in patients admitted in the ICU of the Quran Bessa Hospital from the 1st of May to end of October 2023. Next slide. So coming to the methodology, it was a cross-sectional study conducted in the ICU over a 6-month period. The final sample size was determined to be 216, and this was deducted from a study in South Africa that showed that prevalence of antimicrobial resistance in patients who died was around 21.1%, and the prevalence of antimicrobial resistance in those who survived was 14.6%. And assuming a confidence interval of 95%, a power of 80%, and significance level of 5%, with total patients admitted to the ICU of the Quran Bessa over the specified period being 345, and adjusted for the source population, a double population proportion formula was used to calculate the sample size. And as for the sampling technique, simple random sampling was used. Of the 345 patients registered in the ICU over the 6 months period, only 302 were included, as they had no missing data. Next slide. So the source population were all patients admitted to the ICU of the Quran Bessa, with the study population being those that fulfill the inclusion criteria, which stated all patients admitted to the ICU within the specified time period with cultures from blood, urine, tracheal aspirate, wound, catheter sites, and any of the sterile fluids mentioned, with the exclusion being if a contamination was clearly reported and patients having incomplete records. Next. Coming to the variables, the dependent variable was clinical outcome or mortality, which was dichotomous and categorical. And the independent variables were age, length of stay, comorbidity, site of infection, septic shock, surgical intervention, type of pathogen, MDR, and carbapenem resistance. Some operational definitions for this study, antimicrobial resistance pathogen were defined as organisms that were MDR or carbapenem resistance, or both for this study. Multi-drug resistance was defined as non-susceptibility to at least one agent in 3 or more antimicrobial categories based on disk diffusion test. And carbapenem resistant Acinetobacter baumannii CRAB was defined as detection of any type of carbapenem resistance on disk diffusion test for Acinetobacter baumannii. And incomplete data was which was used as an exclusion earlier, was if any information on either dependent or independent variables was missing. So the data was collected from the HMIS using a structured questionnaire by a general practitioner, and Gobo Toolbox was used for data collection. Data quality and completeness were assured with each collected data by developing data entry forms to reduce error at the point of entry. Inconsistencies were identified by cross-referencing with the primary source, and Excel was used to clean data before analysis. Coming to the data analysis, SPSS version 27 was used. Univariate analysis was done by running frequencies for each variables. Logistic regression was used to look for association between variables, and those variables with a p-value of less than 0.2 in the bivariate regression were accepted to the multivariate regression, where a p-value of less than 0.05 was considered statistically significant. As for the ethical consideration, the proposal was reviewed by both Addis Ababa University and Addis Continental Institute of Public Health, and IRB was obtained from both. Since secondary data was used, informed consent was not necessary for this study. Coming to the results, the study was done in both the pediatric ICU and adult ICU, with the median age being 35 and the median length of stay was 6 days. The commonest reason for ICU admission was surgical, followed by septic shock, around 54% of the patients had associated comorbidity, with the commonest being malignancies, and all infections were monobacterial. There was no fungal documentation. Bloodstream was the most frequently reported site of infection, as you can see from the pie chart, previous slide. Yes, as you can see from this pie chart, the gram-negative infection was predominant, accounting close to 90% of the infections in the hospital ICU. And this is in line with other studies from India and other sub-Saharan countries. And this might be due to their inherent nature to become resistant to most antibiotics. Of the gram-negatives, the most commonly isolated pathogen was Acinetobacter baumannii, followed by Klebsiella pneumoniae, and close to 80% of all isolates were carbapenem resistant. Next slide. Coming to the antimicrobial resistance pattern, 80.1% of the isolates were MDR, which was much higher compared to other studies done in Nawasa and Gondar, which may be due to the difference in infection prevention control and antibiotics used in these institutions. In fact, the study that was done in the Quran-Best Hospital 4 years back showed that MDR rates were 15.5 and 10.7% at the emergency and surgical wards, respectively. This shows that ICUs harbor MDR pathogens more than the rest of the wards in the hospital, which is likely due to the extensive use of broad-spectrum antibiotics. And the highest resistance was seen with cephalosporins and the lowest with amikazine, as it is the second-line anti-TB. And for the fear of creating resistance, it's not frequently used in clinical settings. For instance, Klebsiella isolates exhibited more than 90% resistance to third and fourth generation cephalosporins, but only 30% to amikacin. And mortality in general was more in the Quran-Best as compared to other local institutions. Next slide. So this table shows resistance pattern of isolated microbes, and most, as you can see, are MDR, as they are resistant to 3 classes of antibiotics and more, the details of which can be clearly seen on the last column of the table. Next slide. So this is the final regression table showing that bloodstream infection, septic shock, crab infection were predictors of poor clinical outcome, as evidenced by the adjusted odds ratio and p-value, while patients who underwent surgical intervention had lower odds of dying in the ICU compared to those who did not, with an adjusted odds ratio of 0.46 and a p-value of 0.02. So this is largely consistent with other literatures, as it has been frequently demonstrated that bloodstream infection and septic shock are independent predictors of mortality. As for the crab infection, it might be due to the fact that antibiotics used in the treatment of crab infection are not readily available, especially in the public setup. Harboring MDR pathogen was not associated with mortality, according to this study, and several studies indicated non-consistent results between MDR and mortality. Next slide. So the strengths and limitation of the study. The strengths is in line with recommendations from WHO. This study showed recent information about the common microbes in the ICU and their antimicrobial susceptibility pattern. And so further research are needed to definitely suggest empiric antibiotics. It highlights on what our choice should look like in the future. The high MDR burden found in the study, as compared to other local studies, also emphasizes that work needs to be done on our infection prevention and control strategies. Limitations of the study include it was a single-centered and single-sited study, so it was not representative of other wards, emergencies, and even other hospitals. It was also retrospective, and important information like prior antibiotic exposure, if the patients were on mechanical ventilation or renal replacement therapy, could not be added into the analysis, as the data was obtained from the HMIS. So in conclusion, from this study, we can understand that infections with gram-negative bacteria are predominant in the ICU of the Quran-Best Hospital, where most of them are multi-drug resistance and exhibit high degree of resistance to antibiotics. And these 4 variables, which are BSI, septic shock, crab infection, and medical admissions, were found to be determinants of poor clinical outcome in the ICU. Next slide. So accordingly, my recommendations to the institution and healthcare personnel working there are to strictly follow infection prevention and control measures, employment of antibiotic stewardship programs, and routine surveillance and reporting of antimicrobials. Yes. Here are my references. Thank you.
Okay, thank you, Dr. Aidan, for that compelling presentation. We will now have a short review by our standard lineup of professionals from the field. While we are receiving the feedbacks from our reviewers, If there is any question or feedback from the audience, it is welcomed in the chat box. Feel free to write your ideas there and it will be presented by the end of the review. So first we have Dr. Wondersen Amui, who holds both Doctor of Medicine and Doctor of Philosophy. He's an associate professor of internal medicine and infectious disease at Addis Ababa University College of Health Science. Dr. Anderson has made significant contributions to the field, particularly in the areas of infectious disease and medical education. Please join me in welcoming our esteemed reviewer, Dr. Anderson. You have 5 minutes.
Thank you very much, Dr. Eden. Very good work. But I have a few questions. But always the problem with such kind of studies is to differentiate real pathogens from contaminants and colonizers. So always, we try to focus on sterile body fluids like blood. So what percentage of your study population had a positive blood culture? And, now we'll focus then, the next questions will follow, on the blood culture result, because blood is supposed to be sterile. In the ICU of contamination and colonization. So what percentage of your study population had positive blood culture? Did you hear me, Dr. Eden?
Yes, I heard you, Dr. Anderson. So the percentage of people that had bloodstream infection were around 73% from the study.
Dr. Eden, you will have time to address the feedbacks. First, let's Dr. Anderson finish the review.
Okay, yeah, so the others would be contaminants. So you should focus mainly on the blood culture, the organisms that you grow from a blood culture. It's a common knowledge that, the most often cultured bacteria in the ICU nowadays are Acinetobacter and Pseudomonas. And these are, and then to be followed by E. coli and Klebsiella and E. coli. So these are the most difficult, and from gram-positive Staph aureus. Okay? And regarding to Staph aureus, what we need to know is about the methicillin resistance. Okay, so always in such kind of studies, the limitation is differentiating real pathogens from colonizers and contaminants. Okay, if you get my question and if you respond to these questions, then I would understand your study findings. Yeah. Okay. Now you can comment on the questions I read.
Dr. Anderson, are you with us?
Yes, I finished my questions.
All right.
Let Dr. Eden respond.
All right. Thank you for that insightful feedback. Dr. Eden, you have 2 minutes to address the questions. Those 2 minutes are remaining from the time allotted for Dr. Anderson. You have the floor.
Okay. Thank you, Dr. Anderson, for the feedback. So the first question is with regards to how many percent of the patients had bloodstream infection. It was around 73% of the patients. So the majority were having bloodstream infection. And the study also finally showed that the commonest microorganism was Acinetobacter, followed by Klebsiella. Pseudomonas was not as commonly found in the study. With regards to if the pathogens that were isolated from the culture results were real or contaminants. So we were going through the blood culture records that were saved by the laboratory units of the Black Lion Hospital, and it has shown that there are some reports suggesting that these are contaminants and these are actually real pathogens. So we solely depended on their report.
You see, Dr. Eden, if we grow gram-negative organisms from blood, Candida and methicillin and Staph aureus, then we take it seriously. We don't take it as contaminants. Okay. So now the question is, you know, of these blood cultures, I suppose at least maybe one is enough, you know, in case of blood culture. So did you try to correlate the outcome of those who had positive blood culture, okay, in your multivariate analysis? And what was the adjusted odds ratio? I might have missed it. What was the adjusted odds ratio for those who had positive blood culture? Did you get my question?
Yes, I did. The adjusted odds ratio for bloodstream infection was 2.89 with a p-value of 0.02.
What's the 95% confidence interval? The
It
adjusted
ranges
odds
from
ratio is
one.
low. Hmm?
Yes, it ranges from 1.1 to 3.94.
So how do you interpret that?
So with this, I would say that patients having bloodstream infections are 2.89 times more likely to have a poor clinical outcome as compared to those patients without bloodstream infection.
I mean,
So I would say,
yeah, okay. The mortality was, you know, it used to be very high. Blood culture is positive, but I don't know how. You know, 2 is, you know, it would have been more, but again, it's clear, you know, 2 times more. So from this study that you did, okay, how was the, you know, the other problem that we do have is, did you go to the lab and see how they did the bacteriologic tests and so on? Because one of the problems
Dr.
is, you
Aiden?
know, identifying carbapenem resistance. You know, there are a number of methods. And did you see the lab, how they do it?
yes.
Dr.
So
Aiden?
we,
Dr.
yes.
Aiden, I'm sorry to interrupt. So the time given for Dr. Anderson to review is up. So you'll be addressing the questions forwarded by Dr. Anderson at the end of the review session after the second review.
Okay.
Okay. Thank you, Dr. Anderson, for that insightful review. So next, for our next review, we have Dr. Waka Darajo. Dr. Waka Darajo holds both Doctor of Medicine and Doctor of Philosophy. He is a medical research scientist and specializing in immunology, biomedicine, and biotechnology at Christ Medical University, Germany. Dr. Waka's work area focuses on advancing our understanding of immune responses and developing innovative therapeutic strategies. Dr. Waka, we are honored to have you here, and you have the floor.
Thank you very much. Can you hear me?
Yeah, we can hear you, Dr. Waka. You can continue.
Thank you. Thank you, Dr. Eden, for your nice presentation. Really, I'm very surprised how you present and interpret your presentation, and it's very nice. Especially, I'm very happy that I see some young scientists come to and this very important issue, especially the drug-resistant bacteria. And really, I'm very happy that somebody wants to do work and present this kind of problems and raise to the medical staffs. And you have present very well, and my colleague, Dr. Anderson, has commented important points, and you have to follow him. And before I present my question, I have some suggestions. I think you did very good, but it is better to compare also, not only in Black Light or Ambassa Hospital. Also, you can take some data from different infection referral or specialized hospitals. I have a chance to visit some papers which was done by different referral hospitals. For example, from Harvard, Columbia University, we have seen Wallo University, have seen some papers by Dima University, also in Ambassa in biomedical laboratory, and by Ethiopian Public Health. So you have to see these papers, and they have presented and documented very well, and very important for you. And not all, if you work on this drug-resistant infection, it is better to compare also or to take into consideration another infections, as my colleague said, pseudomonas. It is also very dangerous and very important infection in the hospital, especially by ICU patients, not only in the ICU patients, also in general in the hospital, not only in Ethiopia, also all over the world. It's very dangerous infection cases. And in addition to that, I think most have had a chance to hear and see different master students and PhD students of the Ethiopians, and they're working most of the time this cross-sectional study, epidemiology, and so on. Maybe they may have not a chance to work on in a best laboratory, which is compiled by high-tech. I think it is better to work especially in the laboratory and identify which kind of this drug-resistant species, especially this Acinetobacter baumannii. There are different species, and identify which kind of what type of species inside this bacteria or infection disease dominantly appear in ICU, especially in your institute, in Tekurandasa Hospital or another. And secondly, I think the time is a little bit short. You must increase not only 6 months. I think a 2-year study will be very good for you, but your data in short period of time that is very, very nice. Now let us come to the questions. And you have presented the difficulties and the hardship of this infection disease as it is drug resistant or drug resistant. What do you think in the next 5 to 10 years the mortality and morbidity of this infection disease in Ethiopia? And second question is, if you know or if you forecast this infection disease, maybe the mortality and morbidity will be high or maybe very dangerous, then what is the next step that we are going to do? And what do you recommend the Ethiopian Public Health and the Ethiopian Minister of Health to control such kind of diseases in a short period of time that which may be or that it may be a very dangerous infection in the hospital? Thank you. Did you get the point?
Dr. Waka, thank you for
Yes.
that insightful review. So, have you finished?
Yes, I finished that. After that, if she needs some help, so she can contact us and we'll try to recommend her what type of research she will follow. Finished. Thank you.
All right. Thank you. Thank you so much, Dr. Waka, for this amazing review. So, Dr. Ida, you have now the floor to address the feedbacks forwarded from both Dr. Waka and Dr. Anderson. So you have a limited time. Try to use the remaining 2 minutes, 2 up to 3 minutes in order to wrap up your explanations. So in the meantime, if there is any question from the audience, please feel free to write it in the chat box.
Thank you for your amazing feedback, Dr. Waka and Dr. Wanderson as well. I will look into the reports that were suggested by Dr. Waka and to answer some of the questions that were raised by Dr. Waka. So the first question was what my predictions would be in terms of how resistance will be or how the mortality will actually change in the coming 5 years. And I predict that if we continue with our current practice, the resistance level is going to be out of control. Mortality is also going to surge in numbers that we've never seen before. So my recommendations for this, especially by public health professionals and even by clinicians as well, is one is to prepare different trainings for health professionals and to keep them updated with regards to the proper use of antibiotics. The other is to continue our routine surveillance and reporting. And the third thing is maybe further research must be made, especially in assessing the infection prevention and control measures in different hospitals so that we can actually control and we can guide health care professionals and clinicians. Thank you.
Thank you so much.
Thank you, Dr. Ida, for that insightful presentation, and thank you, Dr. Waka and Dr. Wanderson, for this amazing insight. Now we'll move to our second presentation. Our next presenter is Dr. Migbar Desalegn, who holds Doctor of Medicine and Master of Public Health, as well as being a fellow of College of Surgeons of East, Central, and South Africa, Department of Surgery, School of Medicine, Dr. Marcos University. Dr. Marcos University. Dr. Makonnen will be presenting a retrospective follow-up study titled Perioperative Mortality Rate and its Predictors After Emergency Laparotomy at Dr. Marcos Comprehensive Specialized Hospital, Northwest Ethiopia, 2023. Dr. Makbar, you have the floor. Dr. Makbar, your slide is not moving. Your screen has frozen.
I'm sharing the screens. Okay. Thank you. So can you hear
Dr.
me? Can I
Makbar?
start now?
Dr. Makbar,
Okay. Can I proceed?
can you hear me? Dr. Makbar,
Yes, I can hear you.
your screen is not visible. Your slide hasn't.
Okay. So is it visible now? Can I proceed?
Yet. It's not visible.
Is it visible?
So can you close your screen and start sharing again?
Okay. Okay. Can I start?
You can start, but your screen is not visible yet.
Is it okay now?
No, it hasn't opened yet. Can you leave and join again? Probably if it works.
You mean the Zoom meeting?
Yeah. Your screen is visible now. You can proceed.
Okay, thank you. So I will be presenting about the perioperative mortality and its rates and its predictors after emergency laparotomy. Here is the contents of the slide. So I'll proceed to the introduction. So this emergency laparotomy accounts for about 4.7 million days per year, which accounts about 7.7% of all total days. And this more than half occurs in low and middle income countries. And in our country, about 23 to 36% of the estimates in emergency of the surgeries are emergency laparotomies. And Ethiopia has one of the lowest surgical volumes overall, and the global incidence of this perioperative mortality averages about 4%, but is expected to be doubled in Africa. Nearly 18% of the mortality in Ethiopia is from surgical causes, usually from the intensive care units, and these studies are reported from the intensive care units. Currently there is a target is set that 80% of the countries by 2020 and 100% of the countries by 2030 will track perioperative mortality rate. So this is an ambitious plan, and perioperative mortality of about 1.37 per 1,000 percent has been reported in some studies in Ethiopia. However, this odds of mortalities is expected to be higher among emergency procedures. These studies are based on all-cause mortalities and specific indications. So this study, the current studies, has aimed to determine the status and predictors of perioperative mortality specific to emergency laparotomy. So the objective is to estimate perioperative mortality and predictors after emergency laparotomy at Debre Marcos Comprehensive Specialized Hospital, specifically to estimate this perioperative mortality rate after emergency laparotomy and to identify its predictors. So it was conducted at Debre Marcos Comprehensive Specialized Hospital with a sample size of 418, with sample size calculated from the survival analysis formula using previous study estimates of from another study. And the sampling technique, we used sampling technique of simple random sampling. So the source population are patients who had undergone emergency laparotomy, and these study populations are patients who have been selected in this study period. So all patients admitted and who underwent emergency laparotomy were included in the study. However, laparotomy for simple appendicitis, cholecystitis, trauma, and obstetric causes and transference after emergency procedure and incomplete charts were excluded from the study. So the outcome variable was perioperative mortality rate, and the exposure variables were the socio-demographic factors, preoperative, intraoperative, and post-operative factors were included. And for this study, time means the number of days that the patient has been from the patient's admission to either days or censoring, and event was considered as days after emergency laparotomy within the first 30 days. And censored cases were identified like post-emergency laparotomy and who are alive within 30 days or lost follow-up or transferred to another institution. And by incomplete chart, we mean charts without at least one prognosis note and discharge summary. And we define delayed presentation as symptom patients presenting with symptoms which lasted more than 3 days. So the data was collected using data extraction checklist prepared from the literature review, and those tested on 5% of the samples, and training was given for data collectors for quality assurance, and continuous follow-up was employed. And this data was cleaned, coded, and entered to EPData 3.1 and transferred to Stata, and was analyzed and using survival analysis using Kaplan-Meier curves and log-rank test was run, and proportional hazard assumption was checked, and multivariable regression was done with a decision point of p less than 0.05, and percentages, means with standard deviations, medians, and hazard ratios were reported. So ethical clearance was cleared from Debre Marcos University College of Medicine and Health Sciences, and the results and the discussion. So this is a descriptive result summary. So most of the patients in the study were younger ages, and the female to male ratio was nearly equivalent, and the total events in the study was 76, and the mortality rate was 25.5 per 1,000 person days in the study. Those 2,982 person days in the was analyzed, and the cumulative survival on day one it was 19.4, and it was 19.3 on day 3, with median survival of 18 days. So early post-operative mortality was maybe from non-beneficial surgery, as had been reported in other studies, but in this study, majority of the patients had died between day 3 and day 14, which means that most of these procedures were important for the patient. So these findings are actually higher than the expected compared to the previous national estimations, and severity of the illness, because we included only emergency cases in this study, and delayed presentations and quality of surgical care in other setups might be the reason for such differences. So on the multivariable analysis, the duration of the symptoms greater than 3 days, the preoperative sepsis, and procedure, the ICU admission were associated with increased hazards for mortality. So delayed presentation increased mortality more than twice, and similar studies were reported in Ethiopia as well. And actually, every 1 hour of delay was reported to lower survival by 2.4%. So patients admitted to the intensive care had twice hazard of days compared to those transferred to the post-anesthesia recovery unit or subsequently to the ordinary wards. So in line with this, there were other reports with similar findings, but it's expected to be higher in case of unexpected admission, because ICU admissions might be at times selected. But in our study, most of the patients were not pre-triaged preoperatively to be admitted to the ICU. So, so the vasopressors use had increased the risk of mortality by 80% in this study, which but patients who has undergone laparotomy are in a state of physiologic derangement. So that might be the obvious reason here. So in this study, the study has included only emergency laparotomy procedures and include time of follow-up, which will serve as a baseline for future studies. However, it has some limitations. The outcome and the factors were assessed until the first in the first 30 days after the surgery only, while delayed post-operative complications could occur even up to the upcoming 3 months. So it is a single-center study, and the external validity of the study might be limited. So in conclusion, the findings from this study implied that patients who were operated on lately, admitted to the intensive care unit or with hemodynamic instability, were at increased risk of days. So this suggests the importance of preoperative stabilization of patients through adequate resuscitation, earlier surgical intervention, and monitoring of patients to improve post-operative outcomes is essential. Those are some of the references, and thank you.
Thank you, Dr. Megvar, for the presentation. So, one of our reviewers, Dr. Fasika, was not able to join the session due to network issues in the area. So we'll just have one reviewer for Dr. Megvar. Our reviewer, Dr. Mr. Augicho Kifle-Zamlak, a PhD candidate in biostatistics at Addis Ababa University College of Health Sciences, has an expertise in biostatistics, plays a crucial role in advancing research methodologies and analysis in health sciences. Please join me in welcoming our esteemed reviewer, Mr. Augicho. You have the floor.
Okay, thank you, Noah and Dr. Rehana, for the nice introduction, and thank you, Dr. Magbar, for the presentation. Can you hear me, Dr. Magbar?
Yes, you can proceed. I can hear you.
Yeah, okay. So I found that your research is very important and valuable, and I believe this will contribute a lot for the scientific community. So, it is, I can say, researchable and helpful for the scientific community. Having said this, I would like to uh, give give you some questions for you just for clarity and for enrichment of your document. While you present your research, you are setting the data collection, and it was from January 1, 2019 up to December 31st, 2022. And but in some section you were saying that the data was collected from March 15 up to April 1, 2023. So this means the data is collected within 6 days, like 15 or 60 days. Was it a challenging task, or I just want to hear from you, how do you manage collecting such amount of data, particularly from secondary data within 16 days?
Okay, so thank you. So the time period is the time period that the cases were included. The data collection period has taken some weeks. So it's secondary data. It needs proper clearing of the data from the charts, and some charts might be lost because we use charts that are paper charts is not electronic, so it needs some time for getting the charts and for reviewing. Otherwise, there is another difficulty.
I assume these things, this is very difficult to manage in 16 days, because I know collecting secondary data is a bit tough. It seems a very easy task, but due to our data quality issues, I assume this is a very tricky task. Okay, I assume there will be a lot of missing data and different anomalies, and I would like to know, how do you treat all these missing data and anomalies?
Dr. Magbar, do you have anything to say?
Okay, the question is regarding the missing data. So the missing data, some of the missing data, I mean, the data was collected based on we do have usually the missing data in chart views are related to the conditions that are part of the socio-demographic factors in the chart documentation, but these were complete because of the nursing assessment tools were included well in the charts, so we don't face much missed data. However, we have strictly included only the regarding the laboratory findings. We include only the findings that are worked up in the first admission of the cases. So this has been already in the charts, but inconsistencies are expected in the follow-up of the cases. So these parts of the data, the CBCs, renal function tests, and the laboratory markers were not included in between because we used only the baselines at the appropriate findings that has been investigated while the patient was being admitted. So we didn't face much difficulty in getting these baseline factors because this has been needed by both the teams, so the clinicians, the anesthetists, and the like. So these are already has been done or investigated before the patient has been taken to the operation theater.
All right, great. Yeah, I have seen sample size calculation and come up with a certain number. And again, I I would like to know from where did you get like the mortality or the hazard rate while you calculate sample size?
I just looked for a similar study in other settings. It was one of the studies with actualities from the Indian setup. So we don't have such kinds of studies specific to the emergency laparatomy in our setting. So I took study finding from the India. So we took that values from that study and taking it as a baseline to get this sample size. But we don't have similar studies here in our settings. Most of the studies, it was done in some settings like in Bahrain University and the like, but it included all the cases, including the elective and the emergency conditions. So I just go for the similar studies in other settings.
All right, Dr. Mugbar and also our esteemed reviewer. Due to time, we have to stop here. And if there are any further feedbacks or questions you'd like to forward, you can forward it to us and we'll be forwarding it to Dr. Mugbar. Are we okay?
Okay,
All right.
that's okay. Thank you.
All right. Thank you so much. Thank you, our presenter and also our reviewer for the amazing discussion. So we'll be proceeding to our next discussion. Our next presenter is Mr. Dinga Dugas Aiticha, who holds Bachelor of Pharmacy and Master of Science, Department of Clinical Pharmacy, School of Pharmacy, Institute of Health Sciences at Wellagga University. Mr. Dinga will be presenting his research on the title Therapeutic Efficacy of Chloroquine plus Primaquine in the Treatment of Uncomplicated Plasmodium vivax Malaria at Secha Health Center. Mr. Dinka, you have the floor. Oh, okay. I'm sorry for the mistake. Our next presenter is Mr. Adana Tasfai Ambassi. So I'll be introducing him instead. Sorry for the inconvenience caused. Our next presenter, Mr. Adana Tasfai, is a PhD candidate in human nutrition at Juma University, Department of Nutrition, School of Public Health, College of Medicine and Health Sciences at Lila University. Mr. Adana will be presenting a cluster randomized controlled trial titled Effect of Nutrition Behavior Change Communication on Nutrition, Knowledge and Dietary Practice of Pregnant Adolescents in West RC, Central Ethiopia. Mr. Adana, you have the floor. Adana, are you with us?
Yes.
All right. Sorry for the mistake. We can proceed now. Mr. Adana, can you put your slide in slideshow mode? Are you with us, Adana?
PowerPoint.
Can you put it on slideshow mode?
Okay. Alright.
Adana, can you hear me? Mr. Adana? All right, Mr. Adana has left the meeting. We'll be waiting for him to join us back. we will be joined by Mr. Adana shortly. So in the meantime, if there is
I'm
any
available.
question.
Sorry.
All right, Mr.
Excuse
Adana.
me. Okay.
Sure. You are audible now, so you may share your slides on slide share mode, and you can start.
Okay. Is it visible now?
Yeah, it is visible. And can you
Okay. Okay.
please put it on slide share mode? All right, great. You can start.
It's already on slideshow mode. Okay. So for the inconvenience, I'll briefly share our findings on effect of nutrition, behavioral change, communication on nutrition knowledge and dietary practice among pregnant adolescent in
Audio
West
is not very
season,
clear.
Shashaman in West season. So let's move to the presentation. I'll go from introduction to the list of references. Pregnancy is a profound physiologic change, especially when it comes to adolescents. Adolescents in rapid growth, and on top of that, and
Mr. Adana has left off again. So while we wait for his presentation, if there is any question regarding any of the presentations so far from the audience, please feel free to share it in the chat box and it will be forwarded to the presenters. Your feedbacks and insights are very crucial to the presenters. So please, if there is anything at all, write it in the chat box.
maybe can I proceed?
Yeah, you can proceed.
Yeah, sorry, I have changed my internet connection, and I believe interruption will not happen again.
All right, thank you. Please put your slide in slide share mode.
Okay. Is it visible now?
Yeah, it is visible. You can proceed, Mr. Adan.
Okay, so when pregnancy occurs on adolescent, there are competing demands. So the problem could be to the extent of stopping the growth of the pregnant. So this nutrition partitioning or strong competition of nutrients between the growing adolescent and the child is very challenging. So there are also the potential chance for unfavorable fetal-maternal outcomes like stillbirth, abortion, and small for gestational age and the likes may happen. So the chance of unfavorable fetal-maternal outcomes is more among pregnant adolescents compared with the pregnant adults. There are huge gaps regarding teenage pregnancy. So let alone pregnant adolescent. Generally, adolescents are overlooked population. And our latest EDHS has showed that there were promising improvements in many parameters. However, the neonatal mortality is probably the main parameter which didn't show improvement. Rather, it has increased from 29 neonatal days per 1,000 live births to 33. So this is disappointing and it needs solution. And there is also a high magnitude of undernutrition in the study area, West RC zone, where this RCT has been conducted. And also some studies has showed that in Ethiopia, the nutrition education implementation was very poor. ANC has huge competing topics. Therefore, healthcare providers tends to overlook nutrition education, which is a very cross-cutting intervention. So that's why we conducted this RCT on nutrition behavioral change communication intervention. So the study investigated the effect of nutrition behavioral change communication on nutrition knowledge and dietary practice among pregnant adolescents. And the study was conducted in West RC zone, central Ethiopia. So this study is framed with a health belief model. So the intervention is nutrition behavioral change communication, and it is expected to increase the perceived benefit of balanced nutrition among pregnant, and also is expected to increase their perceived susceptibility, perceived severity of undernutrition. However, it's also expected to decrease the perceived barriers. So for this study, the sample size was calculated considering the intra-cluster correlation for RCT based on similar study conducted elsewhere. And a design effect was also considered because this is a cluster randomized control trial. So we inflate it by design effect. And the average cluster size was about 30, and the dropout rate of 10% was also considered. And the final sample size for this study was about 488. So for the two arms, 244 each was allocated. So the intervention package consists of about 3 different types of, they are the same actually, but 3 different segment of the intervention. And the first was a home-to-home nutrition education based on key metrics like increasing food frequency, the amount, and also food hygiene education, and the key metrics were given. And this the frequency was once per month for 4 months, and it was for 45 to 60 minutes dose. So a compliance parameter was taking attendance. So the second was cooking demonstration sessions, and this was done 2 times in the entire intervention period. And in the cooking demonstration, the proper cooking practice, and also there were demonstrations regarding how food hygiene could be kept and the like. And the last was a leaflet. A pre-tested laminated colorful leaflet was distributed to pregnant adolescents on the key message. Very specific key message were there so that the pregnant themselves or a house member who can read and write could read for them. Here are the data collection variables, about 8 of them. Regarding Wells Index was done, food security from the 9 food security questions, and the dietary practice was assessed by the 24-hour dietary recall, and the 10 food groups were considered, and those having 5 or above were labeled as having unacceptable dietary practice. And nutrition knowledge was measured by 12 questions, and those who answered above 70% were labeled as having a good nutrition knowledge. So the health belief model constructs were also measured on baseline and endline. So regarding data management, data was entered to Kobo toolbox and directly exported to Spaces for analysis. So the major analysis in this study is, since we had a dichotomous outcome variable, both of our dependent variables were having a dichotomous outcome, therefore we have used a generalized estimating equation. We had also used a difference in difference analysis, and the baseline from the control and intervention group, an independent t-test was done. And to compare baseline and endline, there was a paired t-test comparison also. And assumptions for all were checked. Regarding ethical consideration, ethical approval was obtained from Jimma University, and also support letter was obtained from Oromia Health Bureau, and a good clinical practice was followed. When I moved to the major findings, first of all, the baseline finding of both groups were found to be almost similar, no statistical difference. And one of the major outcome is regarding nutrition knowledge. So the magnitude of a good nutrition knowledge in the intervention group was about 23%, and it was improved to 41%. And the good nutrition knowledge in the comparison group was about 23%, and it was increased to 29%. And this difference was statistically significant by the difference in difference analysis. The same is true with dietary practice. There is improvement in nutrition knowledge in both groups, but here in comparison group, there was a slight decrement in the dietary, unacceptable dietary practice in the comparison group. Otherwise, the difference still here is statistically significant. Moving on to the multivariable generalized estimating output, about 3 variables were significantly determining the outcome in the generalized estimating equation multivariable logistic regression output. So, for example, the pregnant adolescents in the richest Wales quantile had 3 times more likelihood of having a better nutrition knowledge. This is the output for nutrition knowledge. So this is regarding the GE output of the 2 groups. So the nutrition knowledge of the intervention group was improved significantly, and this was 5.5 times more compared with the comparison group. Again, regarding dietary practice, the likelihood of having a better dietary diversity practice was about 3.7 times more in the intervention group compared with the controls. When I move to the limitation of these studies, a 24-hour data recall method was used, so it may not reflect the usual or the habitual dietary intake they had, and we demand also a better nutrition assessment method. And a per protocol analysis was used for my today's presentation. So for this may not be directly relevant for policy making, so we should also report the intention to treat analysis, which considers all the participants who started the intervention, despite of their attendance to the intervention, should be analyzed. And so we also acknowledge this limitation. And we need future researches which also considers the micronutrient, because adolescents are, again, very vulnerable for anemia and other micronutrient deficiencies. And this study investigated also only the fetal outcome, the maternal outcomes, or fetal outcomes are also very important. Although they demand a larger sample size, they need to be also considered. And in this study, what I want to strongly speak is about the innovative aspect of this study. The Alliance for Development were used as educators in the nutrition intervention. So we recommend for a task shifting, at least the behavioral interventions can be shouldered by the Alliance for Development because the other healthcare providers, including health extension workers, are super busy with different health extension and health interventions. However, the Alliance for Development or women development armies. Although they had good experience by closely attending what the healthcare providers do, they are not actively engaged in health interventions. So we call for a task shifting, at least some behavioral interventions and health education, nutrition education interventions to this front care for the community level actors. So finally, the conclusion, the nutrition behavioral change communication given by Alliance for Development based on a health belief model was effective in increasing the proportion of pregnant adolescents who had an appropriate dietary practice and good nutrition knowledge. Therefore, we recommend and we suggest the insight of using Alliance for Development for health interventions. And this NBCC should also be based on a model, and it should not be only one-time brief education. So to change humans' behavior, we need at least 3 or more sessions of education. So we recommend for that. And also sideways, there should be income-generating activities. Merely advising nutrition education may not be sustainable. The community should have a good work culture, and the income-generating activities should be there. And the healthcare providers should consider the cross-cutting nature of nutrition and involved in their education. Here are some of the references, and I thank you. I'm done.
Thank you, Mr. Adana, for this presentation. So when we proceed to the feedbacks, we are honored to have 2 distinguished reviewers for this presentation. The first one is we have Dr. Zaudi Adara, who holds Doctor of Philosophy in Public Health and serves as an Associate Professor of Public Health at St. Paul's Hospital Millennium Medical College. Dr. Zaudi has extensive experience in public health research and education, focusing on improving health outcomes through innovative strategies and community engagement. Dr. Zaudi, you have the floor. You have 5 minutes to forward your comments to Mr. Adana, and Mr. Adana, you'll be answering to the feedbacks at the end of the discussion. You will be having 2 minutes. Dr. Adana, Dr. Zaudi, you have the floor.
Thank you very much, Adana, as well as the organizers of this conference. So saying this, I will forward some of the issues I have. So the first thing, the gap you identified is the counseling and education given to health education, by health extension workers is not adequate. So if that's the case, you recommend at the end task shifting to give counseling and education for the adolescents, especially for pregnant ones. So do you think that this is cost effective, and can our country afford such kind of burdens to allocate or to employ additional task force for the community for this purpose? So have you seen that from this perspective? This is the first issue I have. The second one, your intervention is education, nutrition counseling, and then the outcome are the knowledge and dietary practice. Normally in our context, in our country, adolescents, especially females, have no power to determine on resource allocation, or the decision is on the hands of the husband or the family. And most of these adolescents have no their own income. So without this, without having their own income or financial resource, do you think that just giving counseling for this group of people really bring a change in dietary practice? Because the resources are under the control of other people, or they have no job at all. So this is one issue. There is a so-called one Amharic proverb, so really, can we make it practical? Giving counseling for adolescents, especially for females, can bring a change without considering the family or the husband into account. This is the second issue I have. The other thing, I have not seen anything, because it is obviously known that counseling and providing education can bring a change at all. But the way we lack is how can we proceed that? How can we make it effective? Otherwise, Ministry of Health have developed a strategy, as well different partner organizations have developed a strategy. So they are working on counseling as well as educating pregnant mothers, non-pregnant mothers, or mothers with under 5 children to improve the dietary diversity. This is another issue. So thank you very much. For the sake of time, I have just finished.
Okay, thank you for that insightful feedback. Next, we have another reviewer. We are joined by Mr. Kafalo Mulata, who holds a Master of Science in Food Sciences and Nutrition. He's a Senior Program Officer at Research for Development and serves as the country focal point for DataDent, where he works on enhancing data-driven decision-making in nutrition and food security. Please join me in welcoming our esteemed reviewer, Mr. Kafalo. You have the floor.
Thank you, Rihanna. Thank you, the organizers, and thank you, Adana, for presenting this nice scientific evidence. This is really very interesting topic. I really appreciate the title, and because it is the most neglected title in the nutrition arena. Appreciating all the findings, really very insightful. Few pointers to raise. The first one is how do you see the behavior of the intervention targets before the interventions? You know, there are different stages of behavioral change. People's may be on the pre-contemplation stage, contemplation stage, or maintenance stage. So at the beginning, on what stage they were is one of my first question. The second one is, you know, you use different approaches to enhance the behavior. You use leaflets, counseling cards, and other techniques. So how effective was the nutrition education or the counseling activity by itself? How do you see the quality of the nutrition behavior counseling, communication counseling? The other is, I really appreciate the findings you get out of this randomized controlled trial. Is really very insightful. So any recommendation from this research, in addition to those recommendations you mentioned to sustain this AFD, Alliance for Development, to be part of the interventions. By the way, the first question of Dr. Zaude was on the task shifting. Maybe that could be task shifting from health extension. Of course, these are part of the community health agents that are really supporting the health extension program at community level in nutrition education, and they need to be capacitated, but a lot of interventions or supports need to be there. So any sustainability interventions you mentioned. You mentioned a lot of issues. A lot of national documents are there in supporting the youth, adolescents, but they are not effective to the expected level because of different reasons. For example, some of the reasons you mentioned was uncoordinated approach, fragmented under the different sectors, the health, the women, youth sectors, lack of effective policy implementation, funding issue, project-oriented issue. But here, I do have something different view, especially, you know, the sectors are, the user-related issues are fragmented at different sectors because of the current government structures, autonomy, or assignment to deliver the activities. So, and project-oriented by itself is also something, a positive thing, you know, it initiates the use services or adolescent services that could be seen as an opportunity. So how do you see that as a challenge? The other is there difference between the 4 waradas you covered in this study the difference among the waradas by themselves? Do you see any difference among themselves, or difference because of the socio-economic issues, literacy status, education, being near to the health facility or not? Is there any issue that you noticed? The other point is about the quality of the training provided for the FD and the supervisors of the FD. How do you ensure that, yeah, on the approach, when they did, you take it as it is done. If not, and they're labeling as 1 and 0, but is there a standard to ensure that the FD are really very equipped both in counseling knowledge and the skill you used? Is the other question. The other key important point is you used dietary diversity and MOAC, if I'm not mistaken, but these are, you know, and gestational weight gain, but behavior is something a long term, that it is achieved in long term time, but both, especially MOAC, measure, you know, it indicates a short-term impact of nutrition intervention. So how do you look at that? The other last point or question, this is my last question.
All right.
Any noticed behavior on the support of the husband in supporting the woman to have healthy behavior? Finally, just one recommendation. I know the model you used, the health belief model, do have a limitation in measuring the economic or the financial cost for the nutrition behavior activity. But I recommend you to look at the cost. You know, a lot of intervention recommendations are coming out of researches, but because of the financial limitation, such issues are not implemented. Finance is really very important. So costing is really very important. And I also recommend the final impact, the birth outcome because of this nutrition intervention. Thanks so much.
All right. Thank you, Mr. Kafala, for this really insightful feedback. So we are back to our presenter, Mr. Adame. You have 2 minutes to address some of the feedbacks forwarded by our reviewers, and the rest of the feedbacks, you can actually use it as a feedback in your future works. So you have 2 minutes. You have the floor.
Thank you so much. Really, I'm very much grateful for the extraordinary insights. And 2 minutes will not be enough. So what I'm going to do is to address some of the questions, but I'm really very happy to be here and share your insights, especially Kafialo. You shared me a very interesting insights, which will refine my future researches. So maybe some of the questions would be addressed by if you the reviewers and also participants, if you look our publications. So this big research project has led to 5 publications. Recently, this one was also published in BMJ. So the details of those things may be discussed there. And the other is regarding the questions of task shifting. Here, Alliance for Development or Women Development Army is very cheap labor. So in low cost and also in some, giving some privilege of social services, we can easily make them to the system. Otherwise, I understand that we have no adequate budget to deploy new types of healthcare providers. I understand that. And regarding husbands are already incorporated in this interventional study. These pregnant adolescents are not like the others. So almost they are, most of them are with their husband. And also this education is also given for both of them, which addresses first reviewers concern. And Regarding quality of the Alliance for Development training, it's a wonderful question. And what we did was a 1 week training based on pre-test, retest method was used for that type. And also there was a demonstration of the whole intervention, and re-demonstration by the Alliance for Development was made. So an attempt was made to make sure that the quality is maintained. And baseline health belief model constructs were collected. So we knew where they were in the constructs of the health belief model. So it was the baseline health belief model constructs and the endline that we compared. So that way, I think we can compare that. But again, I will appreciate the question that the behavior change, if we do a better behavioral intervention, it's better to see CAP, knowledge, attitude, practice, rather than going to birth weight or something very far. So again, I appreciate the insight there. So 3 of our variables in this regard are CAP, knowledge, attitude, practice. So I think we are free from that in that regard. We didn't look fatal outcomes like just birth weight or something like that. So I think with the interest of time, these are my reactions, but please look at our publications, and that may address some of your concerns, but I respect every point both reviewers have raised. Thank you.
All right. Thank you so much for this amazing discussion. Thank you, our presenter, Mr. Adana, and also our reviewers, Dr. Zaude and Mr. Kafelo. So our final presenter for today is Mr. Dink Aduga Saiticha, who holds Bachelor of Pharmacy. Right. Thank you. So our final presenter for today is Mr. Dink Aduga Saiticha, who holds Bachelor of Pharmacy and Master of Science at Department of Clinical Pharmacy and Institute of Health Sciences, Walaga University. Mr. Dink will be presenting his research on the therapeutic efficacy of chloroquine plus primarquine in the treatment of uncomplicated Plasmodium vivax malaria at Shecha Health Center. Mr. Dinka, you have the floor.
Okay. Can you share? Hello? Hello?
You are audible. You are audible. Right, before we proceed to Mr. Dinka's presentation, I think Mr. Kafelo has something to say. So, Mr. Dinka, please excuse us. Okay, you may proceed, Mr. Kafelo.
I think
Mr.
Kafelo has left the meeting because we proceeded to the other presenter, but he has provided financial support for Adana's ongoing research. I think, Mr. Adana, are you still in the meeting? I think he has also left. This is a very generous offer and something that we really appreciate. And these platforms are meant to create such kind of network and support so that researchers can pursue their career in a better way and do better research in the future. So thank you very much for this opportunity, Mr. Capello. Even if he left the meeting, we'd really like to thank him on behalf of Medical Research Lounge, and Mr. Adana is also a very lucky person to get this opportunity. So I just wanted to say thank you for that. You can proceed. Thank you.
All right, thank you again, Mr. Kafelo. So, Mr. Dinka, you can proceed with your presentation.
Is that visible?
Yes, you are visible. You can proceed.
Okay.
Thank you for having me. I will present on therapeutic efficacy of chloroquine plus primaquine in the treatment of uncomplicated Plasmodium vivax malaria in Sheikh Child Center, South Ethiopia. This is just my presentation outline. Malaria is a persistent public health problem, especially in low and middle income countries, including our countries, and chloroquine has been the primary treatment for early stage of Plasmodium vivax malaria for almost 60 years. However, evidence is gathering for its declining efficacy across much of the vivax endemic world. There have been concern about the emergence of drug-resistant strain of Plasmodium vivax, which has led to the need for a study on the therapeutic efficacy study of chloroquine plus primaquine. Adverse drug antimalarial drug resistance is a major barrier to the control and elimination of malaria, and the emergence of this drug-resistant strain of Plasmodium parasite has significantly impacted the effectiveness of antimalarial drugs in treating and preventing malaria. And the rationale of the studies just globally limited studies with deficiency of therapeutic efficacy on chloroquine plus primaquine. There is a paucity of information in Ethiopia regarding therapeutic efficacy of chloroquine plus primaquine, which is introduced to the guideline in 2018. And several trials have been conducted to evaluate the efficacy of chloroquine, but limited study on chloroquine plus primaquine for treating uncomplicated Plasmodium vivax malaria. Therefore, this study includes therapeutic efficacy of chloroquine plus primaquine by using parasitologic, clinical, and hematologic parameter. The objective, the aim of the study was to assess the therapeutic efficacy of chloroquine plus primaquine for the treatment of uncomplicated Plasmodium vivax at Sheikh Child Center, South Ethiopia. The specific objective is to determine the total cure rate of chloroquine plus primaquine for uncomplicated Plasmodium vivax, to determine parasite, fever, and gametocyte carriage rate, and to assess mean hemoglobin change over time among Plasmodium vivax infected uncomplicated Plasmodium patient, and the other is to evaluate the incidence of adverse events during the follow-up period. The study setting, the study was conducted in Sheikh Child Center, Arbamil town, that's located in the Gamu zone, South Ethiopia. And this is just a single-arm prospective therapeutic efficacy study in patients with uncomplicated Plasmodium vivax malaria. The study was conducted from December 2022 to March 2023 based on standard World Health Organization study protocol for surveillance of antimalarial therapeutic efficacy. The sample size was determined according to the WHO protocol. A minimum sample size of 73 was calculated with 20% increase to allow for loss to follow up and the withdrawal during the 42-day follow-up period. At least 88 patients were recruited, and purposive sampling technique was used. The source populations were all patients diagnosed with malaria at Sheikh Child Center, and the study populations were a malaria patient diagnosed with Plasmodium vivax monoinfection and fulfilled the inclusion criteria. The inclusion criteria were a slide confirmed infection with Plasmodium vivax monoinfection with greater than 250 asexual form of the parasite, lived within 10 kilometers of the rolling health facility, weight greater than 5 kilograms, ability to swallow oral medication, ability and the willingness to comply with the protocol for the duration of the study and to comply with the study visit, able to give informed consent. And the exclusion criteria were severe malaria with complication of sign and symptom, other comorbidities, sign and symptoms of fever, malnutrition, mixed Plasmodium infection, anemia, severe anemia, hemoglobin less than 7 will be excluded. Pregnancy and pediatrics and infant less than 6 months also excluded. The outcome variable, therapeutic efficacy of chloroquine plus primaquine, and the exposure variables are socio-demographic variable like age, sex, clinical variable like the temperature, fever, sign and symptom, hematologic variable, hematocrit or hemoglobin count, and the parasitologic, the sexual and asexual parasite or the gametocyte count. Operational definition, adverse event is just any unfavorable unintended sign and symptom or disease that develop or worsen with the use of medicinal product, regardless of whether it's related to the medicinal product, according to WHO 2009 guideline. The serious adverse event is any untoward medical occurrence that at any dose that result in death or life-threatening that require hospitalization. Per protocol analysis, participants who lost from follow-up period will be, or withdrawn will be excluded from the denominator. The data collection, the study protocol was adhered to, and all data were collected and recorded correctly on the case record form, and the collected data, the social demographic, laboratory, adverse events, sign and symptom, DBS, and outcome data. And the 2 medical doctors and the 1 BSc public health officers were involved in data collection and facilitation process, and the 2 medical laboratory technologists and the 1 WHO qualified microscopist were participating in laboratory data collection. Quality assurance training was given and the supervision was made to ensure the quality of all slides were seen by WHO accredited microscopists from EPHI malaria control director. The data management, the study endpoints were categorized into primary and secondary endpoints. The primary outcome was the 42 overall efficacy of chloroquine plus primaquine, that's stated as polymerase chain reaction uncorrected and corrected proportion with adequate clinical and parasitologic response. And the secondary endpoints were the incidence of adverse event, fever, parasite, clearance, and the hemoglobin level across the follow-up period. The data analysis, data was entered into WHO Excel double entry sheet, which is designed for the analysis of therapeutic efficacy study data. Data was also entered into SPSS version 26, one-way ANOVA and independent sample t-test were used to compare baseline temperature and the parastemia between age group, and the paired sample t-test was used to compare the mean hemoglobin, and Kaplan-Meier survival analysis also used. The ethical consideration, the study was approved by the Institutional Review Board of Ethiopian Public Health Institute, and a written informed consent was obtained from all of the study participants greater than or equal to 80 years of age, or by parents or guardians of children less than 80 years, and the assent was also written informed assent was also given for children between 12 to 70 years. The finding, during the follow-up period, a total of 6,656 patients visited the health center, and 44.2 were suspected percent of were suspected case of malaria, and 4.5 of them were confirmed case of Plasmodium vivax. Over half of the study participants were found in the adult age category, and a mean age of 18.57, and the majority of the study participants were males. The baseline clinical characteristics, from a total of 88 participants, about 97.7 were febrile at the time of enrollment, and the remaining are history of fever in the previous 48 hours. And the mean baseline body temperature was 38.64, and the highest mean body temperature was recorded for under 5 children. Headache, vomiting, nausea were the major clinical signs and symptoms reported during the study at day 0. Baseline laboratory characteristic, from a total of 88 participants at baseline of the study, the mean hemoglobin level was 12.6 gram per 66 gram per deciliter, and 56.8% of the study participants were anemic. This is a primary outcome, cure rate of chloroquine plus primaquine, based on per protocol analysis. From a total of 88 participants, 87 participants completed their follow-up period. From these, 84 were classified under adequate clinical and parasitologic response at day 42 before polymerase chain reaction, and all of the participants were achieved adequate clinical and parasitologic response after the polymerase chain reaction. Before polymerase chain reaction, the 3 participants were categorized under treatment failure as day 42. The study found that chloroquine plus primaquine cure rate of 96.7 before PCR and 100% post PCR, and which is higher than studied then in Adama and Bishoftu before 30 years. The study period is 157 days for Adama and Bishoftu, and the sample size was also higher than this study, and even though the eligibility criteria for both the studies are open and they're similar, and the number of the study setting in case of this study, it's a single center, and in case of Adama and Bishoftu, they are conducted at 2 centers. And it's also higher than study 10 at Kolla Shelle, which is 200 kilometers away from the Arbamish town, and the study period is almost similar with the study, and the sample size is slightly higher than the study, and it's also higher than study 10 in Myanmar, which have similar study period. The strengths, there was only few research studies in Ethiopia, so it will be used as baseline for next study. And this study has gathered data on therapeutic efficacy study. The limitation, the study was conducted at single center, and the comparison of the study finding was held with other countries. And the conclusion, from total study participants, the cure rate of chloroquine plus primaquine was 96.7% before polymerase chain reaction and 100% after polymerase chain reaction. The present study reveals that the cure rate of chloroquine plus primaquine remains high for the treatment of Plasmodium vivax with rapid clearance of parastemia and a fever, hemoglobin improvement, and a good clinical resolution. There is no severe adverse event recurred during the follow-up period. The study supports the current use of chloroquine plus primaquine for the treatment of uncomplicated vivax by National Malaria Elimination Program. Based on this finding, chloroquine plus primaquine should continue as first-line drug in the treatment of uncomplicated Plasmodium vivax in the study area, and a large-scale, continuous, and a strong surveillance of therapeutic efficacy study on chloroquine plus primaquine is needed for early detection and effective control of measure on the possible emergence and the spread of anti-malarial drug resistance in the study area and the country at large. Those are my sample reference. Thank you very much. I've done.
All right. Thank you so much for that compelling presentation, Mr. Dinka. We will now proceed to our reviewers. In the meantime, if there is any question from the audience regarding this presentation or any of the previous presentations, please write it in the chat box and our presenters will get back to it later on. So, moving on, we are privileged to have 2 esteemed reviewers for our session. First, we have Dr. Isaias Kabeda Gudina, who holds Doctor of Medicine, a diploma in Tropical Medicine and Hygiene, and Doctor of Philosophy. He is an associate professor of medicine at Juma University, where he has made significant contributions to internal medicine and public health. Dr. Isaias' research focused on critical health issues, including treatment strategies for bacterial meningitis, and has been actively involved in medical education and community health initiatives. Moreover, through the grant he won from EKFS Germany, he helped improve diagnostic bacteriology at the Juma University Specialized Hospital by the now Juma Medical Center. Please welcome Dr. Isaias Kabeda. Dr. Isaias, you have the floor.
Thank you very much, moderator and the presenter. Also, I'd like to thank you for the invitation to act as a reviewer. The presentation was really informative. For the sake of time, I would like to raise a few questions and leave the floor open for discussion. First of all, with the availability of evidence being raised, there are no enough evidences regarding the therapeutic efficacy of chloroquine or chloroquine plus primaquine in Ethiopia. But to the information I have, there are probably 5 or more than that publications since 2010 for nearly 14 years, the therapeutic efficacy, and all of them showed that chloroquine are effective against PVIVAX in Ethiopia. So what is the rationale to do this research? Because the Minister of Health of Ethiopia has adopted this guideline of using chloroquine plus primarquine as a radical cure for PVIVAX in Ethiopia, and this WHO has already adopted this. So what's the rationale to conduct? Do you think the method you used is more robust than the previous evidences? In line with this question also, it is a proper study design to prove that the approach used by the Ministry of Health is appropriate and to recommend to continue the same. That's first question. Second is, you used in one of the slides, you mentioned as if hemoglobin will be used as one of the outcome to follow the patients. But you said you used patients with uncomplicated malaria, which means we expect hemoglobin to be normal. So what is the validity of using hemoglobin as a treatment response? And then also in the design, you said you used purposive sampling. In addition to the limitation you have mentioned, that's only the single site. This purposive sampling, and which is only single arm, and is an appropriate study design to add to the treatment efficacy of this medication. And do you have a prevalence of G6PD in the area? We know in Ethiopia it's not that high, but there are places in the country where there is a very high, relatively high rate of high prevalence of G6PD deficiency in Ethiopia, like in the Gambela areas. Maybe one last comment. Yeah, I think I will leave with these questions. Maybe I will come back if there are any more based on the responses. Thank you.
All right. Thank you, Professor Isaias. So now we'll proceed to Dr. Girmay Medhin, who is our next reviewer. Dr. Girmay Medhin is a Master of Medical Sciences and Doctor of Philosophy. He's an Associate Professor at Ulama Institute of Pathobiology at Addis Ababa University. Dr. Girmay specializes in pathobiology and has extensive experience in research and teaching, contributing to advancements in understanding disease mechanisms and public health. Please join me in welcoming our distinguished reviewer. Dr. Girmay, you have the floor. Dr. Girmay, are you with us?
Yes.
All right.
Thank you for having me here. Just the subject matter, Professor has already touched on those issues, but I will only look at the methodological part of the presentation. And I had the chance to look into the conceptual framework and the way the lines were linked. I have seen so many double arrows whereby you don't actually expect those arrows. So I don't know whether the presenter has really understood the meaning of conceptual framework, which one leads to which one. So I think I would have looked it back into that one and see what a conceptual framework is. The social science people do understand the conceptual framework, but in areas of medical research, we are not very familiar with the concept of conceptual framework. So the most affects. The other one is I've seen about 4 objectives. They are great, but when you report, if you say these are my presentations, these are my objectives, then which of them are you going to present? Or in a given presentation, you would have probably focused on those specific objectives on which your presentation is going to focus. So total cure rate, yes, you have looked at it, but I haven't seen any result on side effects, or you have monitored them, but you haven't presented in this one. So if you are not going to present those things, then probably you would keep for another presentation. So your objectives should, the objectives that you bring them on the slides should focus only on on areas where you are going to report the results. The sample size issue, well, great, you have done it. But as you know, the sample size formula that you have used actually is meaningful in a condition where the target outcome, which is a binary, is within the range of 10 to 90%. In that level, the distribution of the proportion is normal, so that you can use that formula. But in the rare events where you have the failure aspect that you have used about 5%, in that one, this formula is not great. We don't have it, but at least I would have used a margin of error less than 5%, because with a 5% failure rate, if you use 5% as a margin of error, actually you are also giving a chance of being 0. So people usually use either the percentage of that rate as a margin of error, or some sort of 1%, 2%, and that will definitely increase sample size. So that will be an issue. That is how we do it in practice, but in your future research, just make sure that the formula is applicable correctly. If the target proportion, the linear aspect of part of it, between 15 to 85%, if the proportion is in that level, actually gives you the right number. Actually, you have shown on your flow chart that in the health system, people were actually coming, and then they screened for all different purposes, and then you are focused on patients which are more of likely to be malaria positive. You have said 44.2% susceptible. Then you are actually focusing on them, and then you haven't. You actually did availability sampling, meaning you took all those subjects which are eligible at that point in time. So you have collected all of them, all individuals that were positive within the health system in a given period of time. So would I say availability sampling or complete sampling within a given period defined by the study period? Another element was a recruitment point. There are ethical issues. You have said you have done your ethical approval process, and you have asked consent forms and for children and all those things. But how many of them were children? For how many of them did you take assent? The other part is, at what point in time have you recruited your study participants? Is it part of the health system, or have you done other part of the research? Because when you say took consent form, or you have consent them, at what point in the process of the health delivery system did you recruit your study participants? That is not clear, and most of the time we don't make clear in that area. So that is an area where you have to be cautious while you are reporting your results. The other part, you have listed a lot of inclusion and exclusion criteria, and in order to if you say these were my inclusion and these were my exclusion criteria, have you actually checked those inclusion and exclusion criteria for your study participants? Do you have the data for them? You have said people who were not pregnant. Have you actually tested all of them for pregnant females, and then have you excluded them? Or how many of them were pregnant? If you have done those type of exclusion testing? So on how did you do all those inclusion and exclusion criteria? When I looked on the detailed, interesting inclusion and exclusion criteria, I was doubtful whether if you have actually done them. People actually do write many things, but they don't do those things. So be honest to yourself, and then just include those criteria that you have used. Or otherwise, you have to say, we have obvious things, like you might say, we have excluded mental health issues. But have you done your how did you do your mental health diagnosis? Have you done it? Or is it an obvious part of mental health that you have excluded? So when you say inclusion and exclusion criteria, then people would expect, because of those inclusion and exclusion criteria, we have excluded this much, we have included this type of things. So be cautious on what you say and what you present, and then what you actually write in your results. You have used double data entry Excel for WHO. Probably I would ask you, what is the purpose of doing double data entry? Just to minimize data transcription errors. So be aware that double data entry in any software meaning to reduce data transcription errors. I have seen in one of the areas you have reporting overall cure rates, something like before and after PCR. And I would say, what is the implication of this one? Are we saying that if before PCR, like if you say 95% cure rate, and after PCR, if you say 100% cure rate, what does that mean? Programmatically, are we saying that if you don't use PCR, are we saying that wrongly we are saying 5% of them are and false positives? So what is the implication for at the point of care diagnosis and treatment type of thing? The other one, you have said strengths and external generalizability as part of strength weakness as well. Doing a study in a given health center, in some sense, you have said that is the strengths and the other concept being used as strengths as well as limitations in terms of generalizability of those findings. So these are the general point that I've seen that you might take as a take-home assignments, just to read about all those things and just use it for your things for your future. I'm done. Hello.
Okay, thank you, Dr. Girmay. Okay, thank you, Dr. Girmay. Mr. Dinka, you can proceed to addressing the questions and the feedbacks that are raised by our reviewers. You have the
Thank you, Professor Isaias and Dr. Girmay, for your constructive comments. Let me react on some of the questions. The first question was the rationale to conduct this study. The WHO recommends to conduct or to follow or to survey the efficacy of the anti-malarial drug. Once the drug is introduced into the standard treatment guideline, it should be monitored every 2 years, if possible, or every year. If the resource is available, it is better to monitor the efficacy of anti-malarial drug, especially at least at 6 continental sites of the country. It's better to monitor the efficacy of the drug. Previously, Primakin is not introduced into the market before 2018. After 2018, Primakin is introduced after checking for glucose 6-phosphate dehydrogenase enzyme deficiency. Before we fear Primakin due to the side effect, hemolysis related side effect in an individual having this enzyme deficiency, G6 glucose 6-phosphate dehydrogenase enzyme deficiency. After 2018, the drug is good to introduce this Primakin to the guideline. And the only study that's conducted on Primakin is before 30 years, in 2000, in 2010, it's conducted at Bishoftu and Adama. It's an open level comparative efficacy study, which was conducted on chloroquine, arm and chloroquine plus Primakin. The other is, do you think the method is proper? Yes, it is proper for the such study, for the surveillance of anti-malarial drug therapeutic efficacy study. WHO developed this guideline. The guideline or the method for therapeutic efficacy study is available. I follow that procedure. The other, hemoglobin, we excluded hemoglobin in case of fever malaria. Hemoglobin is one parameter to classify as complicated or uncomplicated. One complication of malaria, fever anemia. Therefore, we excluded fever anemia and hemoglobin. The WHO protocol says hemoglobin is one parameter to assess the efficacy of this drug. Purposive sampling technique. Purposive sampling technique is used if it is yes, it is prone to bias, but if it is not possible, to use the non-purposive or the probability sampling technique, we can use the combinant or the purposive sampling technique. Why I use this is one of the problem associated with the non-purposive, the probability sampling technique. When I come to the Dr. Girmay, the methodology, the conceptual framework, they are double arrow, just to show the association between those variables, the age and parasites, clearance, just to show the association between these variables. And why you present the primary treatment outcome is just the cure rate, and the secondary outcomes are the prevalence of the clearance rates, I mean the parasite, fever, gametocyte carriage rate. Those are the secondary outcome. And on the sample size, yes, expert against malaria and WHO therapeutic efficacy, expert against malaria guidelines that was developed in 2007, and WHO anti-malarial therapeutic efficacy study, which is developed in 2009, recommended this formula to use while we assess the therapeutic efficacy study for anti-malarial drug. If it is not a superiority material, if it is singular material, we can use this formula. And regarding the ethical clearance, are they can we say regular visiting? The patient visit the health center for regular, but we developed a research team in the health center, malaria case unit in the health center. Then we gave training for the healthcare professional, we gave for the laboratory technologists, and we have also one room for malaria treatment unit for the study purpose. First, the patient visits the health center, OPD unit. Then the OPD personnel sent the patient to the laboratory. If it is Plasmodium vivax monoinfection, they send to the research team. If they give consent to participate in this study, we will take the informed consent first. Then we will go to the screening procedure. The screening procedure, we have screening tools. We use that tools. If they are eligible, there are eligibility criteria. We enroll the patient after getting informed consent from the participant.
Mr. Dinka.
Yes.
Can you hear me?
Yes, I hear you.
Please wrap up your explanation. Yeah. Try to conclude your explanations.
Okay, I will finalize it. Okay. Then we check for hemoglobin, I mean, test for pregnancy for all pregnant women. We also perform G6 phosphate dehydrogenase enzyme urine element color test for the initiation of premature. Then if they are eligible, if they fulfill the inclusion criteria, we enroll them, and then we will follow, we will give the medication there in front of the clinician. Then we will follow for 42 days. I have done. Hello?
Okay, thank you, Mr. Dinka. That was an amazing presentation. And also thank you our reviewers, Professor Isaias and Dr. Girmay, for the insightful review. So this was the final presentation for today, and we have now come to the conclusion of our 2 days long annual medical conference. So annual medical research conference. We hope you found the session informative and inspiring. Before we conclude the session, I would like to introduce our guest speaker. Ladies and gentlemen, it's my pleasure to introduce our closing speaker, Dr. Salomon Werkobeza. Dr. Salomon holds Doctor of Medicine and International Master of Public Health. He is also a fellow of Foundation for Advancement of International Medical Education and Research, or FIMER. Dr. Salomon currently serves as a senior advisor to the Ministry of Health in Ethiopia. He brings over 15 years of medical expertise to this role, including 6 years in academia and various positions such as Medical Education Director with IPAC, Continuing Education Medical Education Director at JPIGO, and Senior Training and Research Advisor at Engender Health. As a FIMER Fellow, Dr. Salomon spent 2 years in education leadership at the organization, further enhancing his expertise in medical education. He remains actively involved in clinical practice, teaching, and public health program design. Dr. Salomon's extensive experience and dedication to improving healthcare throughout education and research make him an ideal speaker to close our conference. His insights and perspective will undoubtedly leave a lasting impact on all of us. Please join me in welcoming Dr. Salomon Werko to the stage for his closing remarks. Dr. Salomon, you have the floor.
Thank you so much, Rihanna. You hear me? Am I audible?
Yes, you are audible. You can proceed.
Thank you so much. I think my job is very easy. I'm very pleased to be part of this whole process. I'm very much impressed what I have heard so far. I've been following the sessions the past 2 hours. I'm very much impressed with the quality of papers and insightful reviewers' comment. As being part of this process and my current role in the ministry, looking at the output of all this research finding to improve, patient care, clinical service, and informing policy could be immense. So there is no happier than this day for me, to see this whole thing happen. I just want to start with forwarding a few questions for all of us in this room. We talk a lot about evidence-based medicine in clinical practice. We oftentimes quite hear a lot about it, but I just want us to be very reflective about this. How many of us are actually engaged in generating evidence in this country? How many of the homegrown researchers have actually impacted practice, particularly clinical practice? How many of those of us who've been involved in academic medicine are engaged in generating lots of evidences to improve practice as well as inform policy? How many physician scientists do we have? How many of us who are already in practice in the medical service, be it a pharmacist or a nutritionist, are scientists? These are, looking at the data and the numbers in this country, I would expect that everybody would say very, very few. Okay, given the need, the research output across the country is very minimal. The level that we contribute, the knowledge that we share to the rest of the world is very, very small. And there could be plenty of reasons for this. To mention few, it could be the value that we put into research, which is the research culture in the country. We could mention investment. We probably are not putting enough resource into doing research in this country because it's costly. It's a costly endeavor. It could be our training. We probably are not very well prepared in terms of carrying out very powerful and robust research. Or it could be even the opportunity, the platform, the avenue where we nurture young researchers like yourselves here, you know, getting the chance for you to be able to present your work to your colleagues and seniors and receive feedback and enhance your research skill. So now, having said that, there could be some things that we can do, like the one that we're doing right now. You know, we could create such platform whereby young researchers could learn from the seniors. I've been watching lots of seniors involved here in reviewing the papers and give very insightful feedback. But especially senior researchers could share their wisdom in this sort of platform, and so that we translate all the findings, all the research findings, into improving practice and policy. So I believe in what we've done in the past 2 days had huge and an immense contribution in advancing research in this country. And I've been watching, there is so much academics there, you know, researchers using very powerful, robust method like randomized control trial. And I've been witnessing a multidisciplinary research outputs like the one that we've just heard, you know, in terms of, you know, improving clinical practice through introducing new way of, you know, treatment management in treating malaria. And I believe people have learned a lot from this whole process and being part of this. And all in all, however, there is no perfect research. Even papers published in BMJ are open for critique, and we've witnessed that. So all in all, in sum, I like to appreciate and everybody involved in this whole process, especially the researchers who are vulnerable enough to put out their work for critique. I would also like to acknowledge reviewers, very senior people, very busy clinicians, to come here and want to be part of this process, to share their experience and wisdom. And above all, I see plenty of participants here, you know, taking their time to learn about research, to learn from their colleagues. And above all, I would like to appreciate Dr. Tigis for making this happen. I know, and we're very close. I know I see a lot of potential in her. I know her passion and research. I know her engagement in transforming clinical research and the culture of research in this country. And you know, she has you know shown us a conference is possible. Conference like this is possible, bringing, you know, high experts in research, you know, bringing lots of participants in this platform, you know, to learn from each other, share wisdom. And I hope this will get even bigger. And I just want to thank her and congratulations, Dr. Tix. And last, and my key message to all of us here is going to be, let's do research for informing practice and impact policy. That's the most important message. You know, we don't have to do any research just for the sake of research. Research has to go beyond academic exercise. So as long as we put a lot of resources into it, that has to be put into action. We need to make sure that we use whatever finding that we have from here. And that requires advocacy. You know, whatever research output that we have, it's not enough that we publish it. That has to be communicated to policymakers. And we should, beyond researchers, we all need to be advocates so that our findings, the researches, could be translated into practice. I also like to make a point that we need to keep on collaborating, seek help from each other, you know, support in terms of knowledge, support in terms of resource, and let's continue networking. See what this platform has bring us today. You know, there is financial donation here because we invited people who are working in programs. You know, they have the resources. So bringing people from different walks of life, policymakers, people engaged in programs, people engaged in academia, this platform has shown us that anything is possible by bringing all these people together so that we can advance healthcare in this country. And hope to see more of this in the future. And I'm sure that the ministry is going to see more of this and will be by your side in supporting such kind of endeavors. Thank you all again. Congratulations, tickets, for all of this. And thank you for inviting. Over, Rian.
All right, thank you, Dr. Salman, for this inspiring take-home message. So thank you all for your active participation and insightful contributions throughout today's session. I'm truly grateful for the opportunity to moderate this conference and learn from each and every one of you today. As we come to the end of the second annual MRL conference, I would like to remind you all a link to certificate of participation will be shared in the chat box. I would also like to express my sincere gratitude to our presenters for sharing their invaluable research with us today. Your work contributes significantly to the advancement of our field. I would also like to thank our reviewers for their insightful comments and questions, whose expertise has enriched our discussions. To the audience, thank you for your active participation and thoughtful questions. Your engagement has made this session a success. I would also like to take this moment to invite you all to engage with MRL in the future, whether you are a researcher, healthcare professional, or student passionate about advancing medical knowledge. MRL welcomes your participation in our activities and initiatives. Stay connected with MRL by following us on social media. You can find us on Facebook, Twitter, LinkedIn, and Telegram under the handle @MRL Research. Follow us to stay updated on the upcoming conferences, workshops, and opportunities to collaborate and contribute to the medical research community. Thank you once again for being part of this remarkable event, and we wish all the best in your future endeavors. Hope to see you at another MRL event. Have a good day and stay safe.
Thank you.